Okay, thank you. Okay. Right. Welcome everyone to this session of anesthesia. Right. So everyone, just give me a thumbs up. Let me just see through it. Okay, so good evening everyone. Give me a thumbs up, guys, if I'm visible and audible. Yes? We're just waiting a confirmation from people, and then I'll go ahead with the session. Okay, so let me just start. But if I could just get a confirmation that I am visible and audible. Fine. Okay, so here we are starting with the session for anesthesia. This is basically going to be a revision session, right? Any questions that you people have, you can address me in the chat box, and I'll try to solve it to the best of my knowledge, and I'll share the knowledge that I have. Okay, so how have we planned this session? So this session is more dealing with the image-based questions which are asked, right, and the previous year's topics which are there, so that we do a complete and a fast revision for our NEET PG preparation, right? This is what we are looking at. So again, I can't see any messages from anyone, guys. Okay, anyways, so going forward, we'll start with the important questions. Now this question is what is based on Mallampatti classification. So this is MPC, Mallampatti classification, right? And Mallampatti classification or Mallampatti scoring is a very important topic. This question has been recently asked in the FMGE also. So the very important question, this is there, right? So Mallampatti classification, right, or Mallampatti grading. So when you're talking about the Mallampatti, guys, remember this examination is basically as a part of airway examination. This is a airway examination. Right. Why are we doing the airway examination? So that you can come to know about the laryngoscopy, right? And basically this is going to help you with the intubation of the patient. So what are you going to do then? This helps you to understand which one is an easy intubation, which one is a difficult intubation for a patient who is coming into the OPD. So this helps you to predict any difficult intubation. What is the Mallampatti examination based on? So as I said, we are doing a quick revision. I know all of you people are already aware of things, so I'll just go very fast from here. And if there are any questions or doubts, you can ask me in the chat box, right? So Mallampatti, based on the structures which we see at the posterior pharyngeal wall, based on those structures, we classify them into class 1, 2, 3 and 4. And as all of you know, the structures on the posterior pharyngeal wall are these structures which are at the back, right? So what are the structures which you see over there? You see the uvula, right? You see the tonsillar pillars. You see the fosses, which is the area inside the pillars. We see the soft palate and we see the hard palate. When you see all the structures, it becomes Mallampatti 1, all the structures of the posterior pharynx. If it gets cut like this and the tip of the uvula becomes half, as in the tip is not seen, the pillars and the fosses, soft palate, hard palate are visible, it becomes Mallampatti 2. If only the base of the uvula is seen and no pillars, no fosses, but soft palate and hard palate are seen, that is Mallampatti 3, right? It kind of gets, cut off from here. This is what you see, only the base of the uvula, right? And if you see only the hard palate, right, nothing else is seen and only the hard palate, this becomes Mallampatti 4. So what does it say? It says that when we are doing a laryngoscopy in a patient, the people in whom the uvula is visible, in those people the vocal cords are visible, which is your 𝐒𝐿𝐴 grading, which is the laryngoscopic grading. So therefore, this grading which you see below is the 𝐒𝐿 grading or the laryngoscopic grading. So the Mallampatti classification kind of correlates with the laryngoscopic grading. In Mallampatti 1 and 2, you can see the vocal cords when you're doing laryngoscopy. So they turn out to be relatively easy intubation compared to Mallampatti 3 and 4, where you don't see the uvula. So you are not seeing the vocal cords when you're doing laryngoscopy, which becomes a difficult intubation. So this Mallampatti is important, guys, right? So any questions, doubts? Otherwise I'll go forward, guys. Acha, Dr. Manish का एक message आया. Sir, FMGE question asked in NEET PG also. Yes, it can be asked. It can be asked because Mallampatti is a topic. See, that's what I'm saying. It's PYT. We are discussing PYTs, previous year's topics, which can be a part of FMGE, which can be part of INI-CET, and they are all important. Mallampatti can be asked as an image-based diagram. Without an image-based diagram, it's very important because it tells you to identify a difficult intubation from an easy intubation in a patient, so that you are prepared in case of an emergency, right? You decide that today this patient has to be intubated, and suddenly the intubation is difficult. The patient can lose his life based on that. So this is a very important examination. In fact, it is not just for the anesthesia part. Giving out other knowledge as well. The part is that people are doing it even in the casualty, just to intubate a patient before the surgery in emergency medicine. All this Mallampatti is important for that also. Let's go forward and come to the image-based points. Right. Next, another important topic which was there in the pre-anesthetic checkup was the ASA grading, American Society of Anesthesiologists grading. In the pre-anesthetic checkup, this is again a very important point. ASA grading means it tells you the physical status or the medical status of the patient. Physical status means, or the medical status means, what is the medical history of the patient, right? How is the medical status of the patient before the surgery? I'm not discussing about the surgery. I'm discussing the medical status of the patient before the surgery. So medically, a patient is ASA 1, means normal patient. This was INI-CET question. It has been asked continuously twice. And I think ASA grading was asked even this time in FMGE as well, right? Apart from that, it's a previous year's INI-CET question. So ASA 1 is a normal, healthy patient. Remember, ASA 2 is a mild disease. ASA 3 is a severe disease. There was a problem. If you will see the YouTube channels, a lot of students, when this question was asked in INI-CET, the options they had given was a normal patient, they had given mild, they had given moderate, and they had given severe. So a lot of people, when this question came in exam, they had asked what is ASA grade 3. This was asked in the exam INI-CET, right? So a lot of students had a confusion, sir, whether it is moderate or it is severe. Remember, it is severe. It is not moderate. ASA 3 is not moderate. So remember, moderate is out. Some people like to describe it that way, but textbooks don't mention it moderate. A lot of times it has mentioned moderate to severe, but remember, ASA 3 is going to be a severe disease, right? Which means the medical status of the patient before the surgery is a severe disease, uncontrolled, right? ASA 2 would be controlled, mild disease. This is an uncontrolled disease. ASA 4 is a such uncontrolled disease that it becomes a threat to life of the patient. ASA 5 is a moribund patient who is not expected to survive with or without surgery, right? So ultimately take the patient for surgery without seeing the medical status. And ASA 6 is a brain dead patient. So these are the ASA grading. ASA 1 is a normal patient. ASA 2 is mild. ASA 3 is severe. ASA 4 is a severe disease which becomes a threat to life. ASA 5, someone not expected to survive. ASA 6 is a brain dead patient. This is the ASA grading. It helps us to classify the patient on the medical disease or the medical status before we take the patient up for surgery. Thumbs up, guys. Any questions or doubts? Otherwise, I'll go forward, right? So the next important topic is CPR. In INI-CET, continuously they have asked, like last two INI-CET papers, they have asked questions regarding high quality CPR. This CPR becomes a very important topic. So first what we discussed was the pre-anesthetic checkup, right, where we discussed the Mallampatti classification and the ASA grading. Now we are discussing about the CPR. So CPR is a very important question. You all know the questions come from CPR and they can vary right from 2 questions to almost 5 to 6 questions coming from CPR. It's not just including anesthesia, it will be including medicine part as well. So anyways, let's see how we approach the patient of CPR, because that thing becomes important as to what sequence you are following. Remember, the first thing always is scene safety. It's not look for breath or check for pulse, not at all. The first thing is always scene safety, so that you are safe, the patient is safe, and you can take standard precautions before you start saving the life of a patient. That is what is called as the first step, scene safety. Second step is check for response. Once the scene is safe, the patient is fine, I mean the patient is away, you are not in danger, the patient is not in danger anymore. Danger means from external things. You've taken the patient. For example, someone is collapsed at a building gate, or someone is collapsed on the road itself. You can't do CPR on the road. You have to take the patient away to the side. Someone is sitting right at the gate and is collapsed at the gate. You'll not start CPR at the gate. You'll take the patient slightly away. So remove the obstruction from there, take so that it's not blocking other things. The person is safe and you are also safe. That is scene safety. Second is check for response, whether the patient is responding, yes or no. If the patient is not responding, then you go to the step 3, which is call for help. Till now, we have not checked for pulse and breath. Scene safety, check response, call for help. You ask for help so that you can get the automated external defibrillator, you can get intubation things, you can get the LMA, right? You can get IV cannula, people will come to help you out. Then use what you go and check for the breath and pulse. Till now, we did not check it. So yes, so what we were saying is, as soon as the patient came to us, as soon as the patient came, scene safety, or when we saw the patient being collapsed, scene safety, check response, call for help, right? Once you have called someone for help, then we check for breath and pulse. Remember, they are felt within 10 seconds. Within 10 seconds, check for the breath, check for pulse. How do you check for pulse? You check for pulse basically by the carotid, but you can also check the femoral, and in children especially, we can go for the brachial, right? Breath. Remember, you always look at the visible chest rise. You need to see whether the chest is rising up or not. Okay, so you check the breath and pulse together within 10 seconds. You can get 3 scenarios. Scenario number A, both are present. Breath is also present, pulse is also present. What to do? Nothing. Keep the patient in this position, which is called as recovery position, and this was a NEET PG question and INI-CT question, image based. Okay, this recovery position. Keep the patient at the side. When both pulse and breath are felt, everything is normal. Just the patient is not responding. Only one problem was there, not responding, but pulse is there, breath is there. Keep the patient in the recovery position. Second point, patient is not responding, right? And now you can feel the pulse. This is there, but chest rise is not there. That comes to the second scenario, B. In the second scenario, you will find that chest rise is not there, means breath is not there. So if breath is not there, but pulse is felt, so what to do? Give breath to the patient. That is scenario number 2, where the pulse is felt and breath is not felt. So you're giving breath to the patient. Remember, 1 breath is given every 6 seconds, or 10 breaths per minute is what to be given to the patient. And keep on checking pulse every 2 minutes. This is where you can give naloxone if you find the chances of, if you find symptoms or things related to opioid overdose. You can give naloxone here. Okay. Dr. KK says, sir नमस्ते नमस्ते यार, लेकिन पहले CPR डिस्कस कर लेते हैं, उसके बाद कोई डाउट होगा तो पूछ लेना, ठीक है? Let's go forward. So this was about the second part which I was saying, where the pulse is present and the breath is absent. So what you're supposed to do is give the breath. और breath देते कैसे? How do you give the breath to the patient? All of us know that mouth to mouth breathing, it can be mouth to nose breathing, it can be mouth to mask breathing, it can be bag mask breathing. लेकिन सबसे अच्छा जो होता है वो bag mask होता है, provided if you get oxygen also. I mean, on the roadside oxygen is not possible, but if you get, the best is bag mask or ambu ventilation with oxygen, if you can manage, right? So this is your point number B. Now, a lot of students have even asked me, sir, what if chest rise is present and breath is absent? That scenario is not given. Arey, that is a medical scenario. That is a medical scenario where the patient is breathing and pulse is not felt. So you are going to measure the blood pressure and then the patient is breathing at least now. Patient is breathing. So if the pulse and BP are not felt, what are you supposed to do? Then you'll start to put maybe a central line, there may be hemorrhage, right? You will try to give blood, you will give fluids, you will, at least the patient is breathing. That does not become a part of CPR, right? If the pulse is absent and the breath is felt, patient is breathing, the pulse is not there, perhaps, there may be feeble pulse, loss of blood, there may be hemorrhage, you need to take care of that, right? So this is about the second scenario, I mean, where some people say that, sir, what if pulse was absent and breath was present? So the patient goes to the medical side. You're not supposed to start CPR here. No chest compression, patient is breathing, right? So this is about the second part, number B, where we discuss that if the pulse is present and breath is absent, the other scenario is going to the medicine straight away. You're not doing CPR in that scenario. Here you will do breath, because your breath was absent, so I'm giving breath to the patient. Third scenario, when both are absent, there's no pulse and there's no breath, this is where we start actual CPR, right? This is where we start CPR. This is the third point, C, start CPR. When you start CPR, guys, remember, nowadays the sequence is chest compression, airway and breathing, and we are supposed to do cycles of 30:2. Now this 30:2 was again important question. It was asked in NEET, 𝐼NICET as well as FMGE, this 30:2. Now Dr. S. Yadav says, good evening Dr. S. Yadav. Sir, in trauma, if pulse absent. अरे pulse absent मतलब patient गया, उसमें CPR नहीं करना है, pulse absent रहेगा. Breath पहले देखो, if the breath is present, then you have to handle the pulse. For that you will have to maybe give fluids to the patient. You will start colloids, you will give blood, depending on what the scenario is. Maybe you might have to start dopamine, you'll put a central line, take IV cannula, resuscitate, and think about the cause, that why the pulse may be absent, just like in trauma. Right, Dr. Yadav? Dr. S. Yadav? Correct? But I am talking of a scenario where pulse is already present and breath was not present. Right? And that is where you needed to just give breath to the patient. That was the point. Point number C, A, B is done. C is when both are absent, we have started the cycles of 30:2 and you are doing a chest compression airway breathing, which is C, A and B. So therefore chest compression is supposed to give the cardiac output. A is for airway, so that the airway remains patent or open, any obstruction is removed. And then what you do is you give breath, because once the airway is patent or open is when you can give the breath to the patient. So chest compressions normally are given at the, remember important point, lower 1/3 of the sternum. These are the points of high quality CPR. Lower 1/3 of the sternum. Hence you get fracture 5, 6, 7. Right. Rate is 100 to 120 per minute. This time 𝐼NICET question. Normally the depth is 5 to 6 centimeter or 2 to 2.4 inches, and the question this was asked in 𝐼NICET was they had given 3 to 4 centimeter, right, which was the wrong option there. So 5 to 6 centimeter or 2 to 2.4 inches, that is supposed to be the depth of chest compression. Always let the chest come back, allow for recoil. To keep the airway patent, you need to remove an obstruction. If the vomitus is an obstruction, if the bleeding is an obstruction, if a foreign body is an obstruction, just take it out, right? And in case if the patient has fallen down and the tongue has fallen back, you need to do the maneuvers, which is called as head tilt chin lift. This image has been asked in exam. Head tilt chin lift, and then this is not supposed to be done in fracture cervical spine. Where you suspect fracture cervical spine, you can't be doing head tilt chin lift. Not possible. There you do jaw thrust. A lot of people combine all of the three together and they call it as a triple maneuver. Head tilt chin lift jaw thrust, but normally head tilt chin lift are done in most of the patients, but if you suspect fracture cervical spine, you do the jaw thrust. And then once the airway is patent, then we give the breath to the patient. As I said before also, the same mouth to mouth breathing, bag mask is the best one if it's possible. You always give 2 breaths at one time. Inspiration over 1 second, look for the chest rise. Expiration over 1 second, right? And no excessive ventilation. So these are the points. And what are we supposed to do? We are basically giving cycles of 30:2. So this is what we are supposed to do. 30 chest compression, 2 breaths, 30 chest compression, 2 breaths. So you're going to do 5 cycles, so basically finish off in a period of 2 minutes, right? And after that you check for the pulse. If the pulse is present, patient is fine. If the pulse is absent, repeat the whole scenario again. So that is how it goes. You are doing the chest compression airway breathing. You're continuing that. So you're giving 30:2, 30:2, 30:2. You're giving that in a period of 2 minutes, right? After that you check for the pulse. If the pulse is present, patient is fine. If the pulse is not there, if there are 2 people, rotate the compressor and then again start with that 30:2. And this whole thing can continue for 30 to 40 minutes or till the time ELS people arrive. What if you get a defibrillator now? If you get a defibrillator, add the defibrillator here itself, right? Immediately check for the rhythm. The dying rhythm normally are 2 of them. One can be pulseless ventricular tachycardia, other is ventricular fibrillation. Other side you have pulseless electrical activity and asystole. So pulseless ventricular tachycardia and ventricular fibrillation are called the shockable rhythms. Pulseless electrical activity and asystole are non-shockable. So ventricular tachycardia is this, right? Ventricular fibrillation is something like this, fibrillation of the ventricle. Pulseless electrical activity is going to be something like this, and asystole is a flat line. So therefore these 2 are the places where you're going to give shock. These 2 you're not going to give shock. Simple. So once you get the defib, attach the pads, check for the rhythm. If the rhythm is shockable, you need to give a shock immediately. Do not do a pulse check and start your CPR, the same 30:2, 2 minutes, and then check for pulse. And after that, now once a pulse is absent, then again check for the rhythm. And if the rhythm is there or not there, based on that you will decide if the shock is to be given or not shock is to be given. And after that you will start with 30:2, right? So this is what we have done, is that in the basic what we were discussing, cycles of 5 cycles of 30s to 2, what we did was we checked for the rhythm here. The first thing we are doing now here is check for the rhythm. If the rhythm is shockable, you give a shock. After the shock, you start with the 30s to 2 for 2 minutes, then check for pulse. If the pulse is not there, again then don't go for 30s to 2, then you go for the checking of the rhythm, right? If the rhythm is not shockable, then straight away you start for 30s to 2. So basically point is, instead of just straight away 30s to 2, if you get a defibrillator, you are always going to first check for the rhythm. If the rhythm is shockable, give the shock. If the rhythm is not shockable, then straight away start CPR. That's the whole point. Okay guys, so that was CPR in short. Thumbs up everyone. In short, hopefully in short, and you people have understood, right? High quality CPR is an important point which I discussed with you. At least 2 inches, 100 to 120 per minute, chest recoil, minimize interruptions, avoid excessive ventilation, 30s to 2, right? And 2 important monitors which are given, right? 2 important monitors which you do. Now this is what is given in ACLS. This chart what you see is ACLS. So how is ACLS different from BLS, guys? ACLS is different, as you will see. Now you have got basically, if you can see, people have come to help you. You had called people, remember? Scene safety, check response, call for help. The people who have come to help you, they have got defibrillator, they have got intubation trolley, they have got LMA, they have got monitors. So now what we have done is, the difference between ACLS and BLS is that it's become advanced. You already have endotracheal tube, you have laryngeal mask airway. So now what is happening is, you don't have to do that 30s to 2. You straight away give chest compressions 100 to 120 per minute. The breaths will go at 10 to 12 breaths per minute, and they are irrespective of each other. In ACLS, if you have endotracheal tube, there is no 30s to 2. That's the point. Okay, that is the difference between ACLS and BLS. In ACLS, what again happens? Not ACLS, I'll say ALS, advanced life support, rather than basic life support, advanced life support. Now people have come to help you out. They have the IV cannula, so you can take the IV access, right? So you can take an IV access. Not just that, in case you don't get an IV access, if it's a burn patient, what do? Go for intraosseous line. And it's mentioned, and this intraosseous image was asked in the exam. Where is intraosseous? This is intraosseous. Okay, so you take an IV cannula or intraosseous. This intraosseous was an image based question, so this is what is called intraosseous line. This is to be taken in case of an emergency. The most common site that you use for that is the tibia. Apart from tibia, you can also use the femur. There can be humerus, anterior superior iliac spine, and the sternum. But the most common for intraosseous site is the tibia. In case of an emergency, this is where you can give the fluids and help to resuscitate the patient. Correct, Dr. Carpal tunnel. नाम भी तुम लोग अजीब रखते हो ना, carpal tunnel. मैं हर बार बोलता हूँ. Whenever I'm there on YouTube, I always say that. You know, like there are few people who have written proper names. Carpal tunnel. What should I write my name? बेहोशी का डॉक्टर नहीं. Licensed drug dealer. Better name. Dr. S. Yadav says 18 gauge cannula. See, anesthesia is a branch, na, like this only. That's why I say next time you will say, next time the class we'll say, we'll not say the class by Dr. Vinish. We'll say class by the educated drug dealer. ठीक है? क्या करें यार, तुम लोगों का नाम भी ऐसा ना, कार्पल टनल. that person must have had such a good name, you know, and rather than on YouTube I'm addressing as carpal tunnel, Dr. Carpal tunnel. So next time you should address me, Dr. Licensed Drug Dealer. Chalo, let's go back. Well, people will ban me from YouTube then, just by uttering the words. You never know. Okay. Anyways, going back. Where were we? Chalo. IV cannula was a question asked by Dr. S. Yadav. 18 gauge, we can use 18 gauge, but as Dr. S. Yadav, what I'm telling is that in case you have a patient where you don't get an IV cannula, then what you will do? That is the point when you're supposed to take the intraosseous line. In case the IV access is not possible and you need to save the life, right? Something has to be done in an emergency, especially the burns patient. You know, when you get burns patient casualty, all of you have worked in government hospitals. You know, when you get a government. Dr. Carpal tunnel says, I don't want my friends to know me. But why don't you want your friends to know you? What difference does it make? It's okay, yaar. Don't worry about the world, don't worry about the friends. You don't have to care about everyone. Care about yourself and care about your parents. That's it. No, nothing else is more important. Care about yourself and your parents. Rest, everyone is not important. यही problem हो जाता है यार, friends. You must have had such a good name. Rather than me trying to say Dr. Carpal Tunnel got Dr. Carpal Tunnel. ये फ्रेंड्स लोग ही लाइफ खराब करके रखते हैं. सीरियसली हाँ, कभी सोचना. नहीं फ्रेंड्स आर इंपॉर्टेंट, मैं मना नहीं कर रहा हूँ. आई एम नॉट सेइंग यू डोंट नीड फ्रेंड्स, यू नीड फ्रेंड्स. बट जब पढ़ाई होती है तब पढ़ाई, और जब फ्रेंडशिप होती है तब फ्रेंडशिप. ठीक है, both the things have to have their things. चलो let's go back to studies. Where were we then again? बेहोशी का डॉक्टर. अब ना सब लोग डिविएट हो जाओगे. तुम लोग को थोड़ा सा टाइम मिल गया ना अभी, थोड़ा सा वो आई नो नीट पीजी रियली हैज गॉट, इट्स रियली सैड दैट इट्स गॉन हियर, बट नाउ एवरीवन हैज गॉट टाइम. सब लोग थोड़े से रिलैक्स हो गए. रिलैक्स नहीं होना है. नो वन इज सपोज टू गेट रिलैक्स्ड. ओके, चुपचाप पढ़ाई करना है. एम इज टू गेट द सीट. इट्स एज सिंपल एज दैट. ओके, डॉक्टर भौमिक says NIPER 2027. Hi guys. चलो anyways पढ़ाई कर रहे हैं. डॉक्टर एस यादव had asked me the question, so I gave the answer. IV, if in case if it is not possible, is when you go for the intraosseous access. Going back to what I was discussing. So I was just telling that what is the difference between ALS and BLS. So I just told you कि initially you have the endotracheal tube, then there's no 30:2. IV access or intraosseous access is there by which you can give the drugs, right? And the drugs used can be adrenaline, they can be amiodarone, there can be lignocaine, and there can be magnesium. Toss I do the point is. Apart from that, no other drugs are used in ALS, right? These are drugs used, and you can use a monitor. What are the monitors used? EtCO2, capnography, and diastolic blood pressure waves. These are the things which make ALS different from BLS. And here you have to keep on thinking about the 5H and 5T, which they ask in the exam. 5H and 5T. I will be sharing this chart with you, this PDF with you, so don't worry, you'll be knowing the answer. Okay. Okay, yes sir, my name is Bhaumik, he says. Nice, great Dr. Bhaumik, great. ठीक है, this is such a good name you have ना, Dr. Bhaumik. Okay, चलो आगे चलो. Next, identify. So all of you are there. Identify. What is this? Image based question. Identify. Identify. I am not giving the options. I know exam you are going to get options. I am not giving you the option. जल्दी identify. तब पानी पी ले. Yes. PICC central line, correct. It's a central line, right? Central line is also called as a central venous catheter, right? And central line means it lies in the central vein of the body. Important point, where does the tip lie? The tip of the central line lies at the junction of the superior vena cava and the right atrium. Important point. And therefore you can have complications related to the heart also, right? So now the point is the tip of the central line lies at the junction of the superior vena cava and the right atrium. What are the sites from where you can insert it? So you can insert from the internal jugular vein, you can insert from the subclavian vein, you can insert it from the femoral vein, you can also insert here at the basilic or the cephalic vein. Right, so these are the 5 places from where you put a central line. Important, central line goes in the vein and not artery. Please read your options before you mark this answer. Okay, otherwise sir, subclavian artery, tick mark. That is where we make the mistake. I set up this question. This question is there, which I have normally set, where I have given subclavian artery, internal jugular vein, then there is basilic vein and cephalic vein. No one sees that I have given one option as artery. They see subclavian, tick, this tick, sir, basilic or cephalic, this is the correct answer. No yaar, ये पीछे vein है, this was given as an artery. Please read that it is an artery which has been given as an option. So this artery is wrong, it is supposed to be inserted inside a major vein. Okay, correct. I am coming to the thoracic duct injury also. So now what are the complications? The complications would be you are putting the line inside the vein and right next to it is the artery. So you can puncture the artery straight away. Right, so of course immediately what can happen is an arterial puncture, which is most common. Arterial puncture, and the central line is going to the heart. It can damage the heart also, right? And then there can be arrhythmias because you're touching the junction of superior vena cava and right atrium, so there can be arrhythmias. Now you are lying this, when you're putting a central line, apex of the lung is there, right? And this can cause pneumothorax, correctly mentioned by Dr. Your drug of choice. ये देखो एक और नाम. Nice. Correct. So that is pneumothorax. Remember, pneumothorax can take in both the places left or right, but In case of a left-sided subclavian or a left-sided internal jugular, remember the thoracic duct goes here and this can lead to chylothorax. This was INI-CT question last year. Okay, this was the image based question which was given, subclavian line insertion and when you're putting it, thoracic duct is going there and therefore it can lead to chylothorax. Okay. So pneumothorax, chylothorax, they become important. Apart from that, the usual things, you know, local bleeding, local hematoma. I'm not going to embolism or forget all that. A lot of people say it's used for the treatment of embolism also, but if open to air, it can cause embolism, right? But bleeding, infection, hematoma, we're not going to do those details. Important point is arterial puncture, heart. It can damage the heart also. At heart punch, it can take puncture. It can puncture the heart. It can create damage to the heart. There can be arrhythmias, pneumothorax, and chylothorax. These are 5 important things which are asked in the exam. And chylothorax, remember, especially on the left side. So please see this question in case if it comes on the left hand side. Peripherally inserted central line का बता दो, says doctor. Peripherally, देखो, that is more common use for onco surgery. PICC ना. PICC is normally for what are the uses of a central line then? Central venous catheter is a access to the venous circulation, right? So because it is access to venous circulation, you can give total parenteral nutrition from there, you can give chemotherapy from there. So that PICC is a very important thing for chemotherapy. Apart from that, from the central line, you can do pacemaker, transvenous pacemaker of the heart, right? You can do even the dialysis catheter can be inserted. You can give vasoactive drugs from there. These are the medical things. You measure the CVP, which is normally 8 to 10 centimeter of water. It is telling you the fluid status of the patient. Apart from that, in turn, you can do blood collection, right? And correct, that's what I'm saying. So PICC is normally inserted in the patients who are undergoing chemotherapy, right? Because chemotherapy is to be inserted, and those patients, you don't get IV line. So you insert a peripheral inserted catheter, central line, from where the chemotherapy can be given. So that is the basic use for a PICC. Normally that is where PICC is used. According to me, if you can speak to medicine people, they can give some other answers also. I am telling you from the anesthesia point of view and the critical care point of view. Okay. Next, that was the central line. This is the arterial line. This is the difference between them. An arterial line is put inside the artery. Central line was put inside the vein, and the most common site to put a arterial line is the radial or the ulnar. And this question was again asked last year, INI-CT. What was this? This is what is called Allen's test. Allen's test. Doctor, your drug of choice says we have to put heparin before blood collection. Arey, kisme heparin? See, heparin, normally what we do is there is something called as heplock. You don't want, wait. People have all gone into critical care, all of you. So what you know, very normally, can you see there is blood over here? ये exam में नहीं पूछेंगे, but ठीक है, because you people are having doubts. For me, it's better to clear those doubts also. It's important. Good. You people are basically observing. Can you see there's a blood over here? If the blood is on the central line and you try to push a medicine from here, how will the medicine go inside? So what you need to do normally is when you've given a medicine or you've done a blood collection, in that case you put heplock. Heplock is sort of, heparin which is used, and we dilute diluted heparin and we just insert about 1 ml, and what does it do is prevents the clotting in these lines, the clotting which is there. You can see this clot over here. See, this line is clear, but if you will see, this line is clotted. So the use of heparin is to prevent the clotting which takes place. So that's what we do now. We normally do it once or twice a day, not more than that, right? And it prevents this clotting which is taking place. Otherwise, what will happen? This central line is going to get blocked. If you see, if there's a clot forming over here, how will you insert any medicine from here? How can you give chemotherapy, right? What can be done from there? Nothing. So one line is getting blocked, and to prevent that is where we use heplock or heparin. Okay. हाँ, heparin is used for bleeding. वही तो point है ना, clotting fever prevent कर रहा है ना, Dr. S. Yadav. Bleeding मतलब you're not trying to put inside the circulation of the patient. You are trying to prevent the clot formation over here. This is where you're trying to put that heparin. Okay. Anyways, let's go forward. Next point. We were discussing the arterial line, radial and ulnar. Okay? And I was telling you radial and ulnar डालने के पहले this question was asked in the exam, which is Allen's test, right? Allen's test, it should get filled up in 7 seconds, less than 7 seconds, and this establishes the collateral circulation, right? It means that the circulation is patent, the collateral supply is fine, right? So this question is there as a part of surgery or a part of anesthesia also. Okay. So Allen's test, less than 7 seconds it should fill up. This is the arterial line. An arterial line is basically used for invasive blood pressure measurement, and you can do a arterial blood gas collection from there, ABG. Okay. Next, IV cannula, all of you already know it. Just remember these flow rates are important. The most common used is the pink colored one, which is the 20 gauge, and the flow rate is around 54, right? The ones smaller to it are 22, 24 and 26. Remember, if the number goes up, it becomes more thin, right? So yellow one is what is used basically in a pediatric patient, can be used in neonates. 26 is what is used in neonates and preterm neonates. The blue one, it can be used in adult as well as pediatric, right? And all this orange, gray and green, these are thick ones. They are used for blood and fluid resuscitation. Blood and fluid resuscitation. Okay? Clear? So now the point is, Dr. Bhaumik, उस पे आता हूँ मैं बाद में, ठीक है? I'll come to that later on, right? It depends individual condition what you're asking me. But let me finish off the point on the anesthesia, right? Let us discuss the points from anesthesia over here. Let me finish off that. So I was discussing with you the cannula numbers. So pink one is 20, blue is 22, yellow is 24, and the purple, this purple which I've not put it over here, that is 26. 18, 16 and 14 are the thick ones. The flow rates are basically 54 for the pink one, 20, remember 24 and 20 over here, 13 to 15 is for 26, and the remaining, these are the high flow rates, ml per minute. Sometimes they have asked you about the ml per minute also. Okay, so just be careful, you're supposed to be knowing it when we're discussing the IV cannula, right? I've already discussed with you the intraosseous line. This is the intraosseous line. This image was asked in the exam. Going forward, another important question is oxygen delivery devices. All of you know, right? Purple is 13, correct, that's what I said. Purple is 13, purple is 13 to 15. So that's what I mentioned, right? Doctor, your drug of choice. Doctor, your drug of choice. What is your drug of choice? My drug of choice, ketamine. My drug of choice, sevoflurane. 2. Your drug of choice, doctor. What is your drug of choice? I told you my drug of choice, huh? My 2 drug of choices are ketamine and... ketamine was this time question asked in FMGE, huh, by the way. Ketamine was this time question, and what was the question asked? Which of the following is NMDA receptor antagonist? Options given were thiopentone, propofol, ketamine, etomidate. Correct answer is ketamine. Okay, it was this year's FMGE question, Abhika, NMDA. Okay, remember that, huh? Such questions come in the exam. Next question, we are discussing oxygen delivery devices. Remember, oxygen delivery devices are classified into 2 types, low flow and high flow. Low flow devices are basically your nasal cannula, simple face mask, a partial rebreathing mask, or a non-rebreathing mask, right? Nasal cannula normally works between 1 to 6 liters, and the maximum you get is 44% FiO2. Right? The simple mask, correct, is called a Hudson mask. It works between 5 to 10 liters. The maximum you get is 60% FiO2. Forget about the partial rebreathing, they'll not ask you. A non-rebreathing mask is basically having a one-way valve. So it has a valve over here, you can see. So it has a reservoir bag. This is the reservoir bag, and here is a valve. These are the 2 things which make it a NRBM. So this is a valve and there is a reservoir. These 2 things are making it a NRBM. Reservoir plus a valve. NRBM basically works between 12 to 15 liters. It provides almost 90% FiO2. So the maximum FiO2 is given by non-rebreathing mask, right? These are the low flow devices. For the nasal cannula, remember there's a formula, 20 plus 4 into the liters per minute, flow in liters per minute. This tells you the FiO2. So for example, if I start the patient on 4 liters per minute oxygen, so how much is the FiO2? 20 plus 4 into 4, matlab 16, which is 36%. So if I start a patient on 4 liters of oxygen, you get 36% FiO2. This formula is for nasal cannula. A question based on this was asked in INI CET last year. Okay. Another good name now. I like the name Legendary Dr. Ritvik. Great. Nice name. You know, you people are giving me ideas to make my name also different next time onwards. Okay. Anyway, so simple. अपना first हो गया low flow devices. So these are the low flow devices: the nasal cannula, the Hudson mask, the partial rebreathing mask, and the non-rebreathing mask. So these are normally used for patients who are normal, stable, and all. This is what is called as the high flow devices. So there are two high flow devices you people need to know. High flow. There are two of them. This what you see in front of you. This was asked as an image based question, especially during the COVID time. I think it was 2022 or 23 when they asked you this question. No, 21 or 22. This is what is called as the, anyone? What is this called? This is, can you see? It's like a nasal prong only, right? It's not patient not intubated. There is a humidifier present here. This is what is called as a high flow nasal cannula, right? High flow nasal cannula. So high flow nasal cannula, guys, remember, works at 60 liters and it can provide 100% oxygen. High flow, okay, 60 liters pe it is providing 100% oxygen, and because it has this humidifier, this is the humidifier, so it provides warm oxygen to the patient, warm and humidified. It provides warm and humidified oxygen to the patient. This image was asked in the exam also. This is high flow nasal cannula. Another high flow device which we think normally is not a high flow device is Venturi mask. This is what is called as a Venturi mask. So this attachment which you see is what is called as a Venturi mask. This normally is used where you need titrated doses of oxygen. For example, a patient of COPD. All of you know, if COPD patient is given 15 liters of oxygen, he will go straight away to God. Okay? He will stop breathing. A COPD patient comes in acute exacerbation in the casualty. You are the doctor on duty. You find the COPD patient has saturation of 60%. What you do is, all of us, the person who is working as an intern, 15 liters. To a COPD patient, you give 15 liters of oxygen. NRBM, 15 liters, 90%. And you find the Babaji is gone up. He's up. You can't do that. Here you have to give titrated oxygen. In a COPD patient, I don't want the SpO2 to reach 100%. In a COPD patient, I am happy if the COPD saturation is 88%. He will survive. If I make his saturation 100%, he will die. He'll stop breathing. Hypoxia is what is needed in these patients to breathe. So I will try to keep it around 88 to 90%, and therefore I need to give him titrated oxygen, and therefore I need something which is called as a fixed output device. So this is what works as a fixed output device. If you will see previously, whether it is a nasal cannula, whether it is a Hudson mask or a non-rebreathing mask, everywhere I've told you it's 44% maximum, 60% maximum, 90% maximum. But I can't tell you whether it is going exactly or not. It may be going, it may not be going. But when you use a Venturi mask, you know how much is going. You take the green one, you know it is 60%. And 60% at 15 liters. Remember, that is called as air entrainment. It causes air entrainment. This Venturi mask is based on Venturi principle, which is the Bernoulli's law. Okay, air entrainment it causes, and therefore it is giving around 60%, right? So at 15 liters it provides 60%. So remember, though it is a high flow device, a Venturi mask does not give 90% oxygen. It is a fixed output device. You know how much is going to the patient. So if I use the red one, I know 40% is going to go to the patient. So if I have to titrate it further, I have to come down. So after that, what I will do, I will use a yellow one, 35%. Then I'll go to orange, 31. And then this patient will become normal, and that is how you use the Venturi mask, right? It's a fixed output device. Everyone okay? So these are oxygen delivery devices. Thumbs up, guys. As I said, I'm discussing more of these image-based questions and the previous year's topics which are there. Huh? Any questions and doubts, please ask me in between. अरे कोई डाउट नहीं किसी को? All good. Okay, so let me go forward. Another important topic, intubation and LMA. Can't remember the color. No, you don't need to remember the color. No. These colors are not important. They won't ask you. Don't remember the colors. Just remember the maximum FiO2 is 60% and it is less than NRBM. This is where we get confused. They are not going to ask you color of your color, because normally nowadays it's not even color coded so much. Nowadays what is happening is you are getting a single tube which you can adjustable hai. If you adjust this opening na, in that one tube only, it's all green colored nowadays. There is one green color small venturi mask you get, and you can attach it at the back of any face mask, right? So nowadays they are not going to ask you these colors. Don't worry about it. They are not going to ask you, right? Don't remember color for this. Color important है cylinder में और vaporizer में. That we'll discuss. हाँ, चलो कलर की बात करते हो, सबसे पहले कलर ही डिस्कस कर लेते हैं. If you're okay. Before we go to laryng, since we discussed colors ना, let's go to colors straight away, so that we don't have a problem. Colors. Okay. So these are important colors that we need to know, right? So these are all your cylinders. So these are the colors which are important. So there are 5 cylinders. They ask you commonly. Air. This is gray body with black and white shoulder. Pin index number. What is pin index? Pin index is something which prevents the wrong attachment of cylinder. Means if this is the pin on the anesthesia machine, the corresponding are the holes or grooves or the pin receiver on the cylinder. This will fit into it. But if you will see, इसमें लिखा है air. ये है nitrous. ये है oxygen. So if I have to replace this oxygen, it will go and fit only here because this number is 25. This number that you see is 35. This number here is 15, air. So if I want to put 25 over here, it does not go. If I want to put this number 35 over here, it will not go. This is made only for cylinder of air. You can't put oxygen over here. You can't put nitrous over here. This is your pin index safety system. Okay. So pin index safety system prevents the wrong attachment of cylinders, right? So air is gray with black and white shoulder. The number is 15. The next one is oxygen. This you have black body with white shoulder. This is 25. You have nitrous oxide. These are 3 important ones, blue and 3 and 5. So these 3 are the most important that you people need to know. Apart from that, Entonox is a combination of this. Entonox. The biggest name has the biggest number 7, right? Entonox. So this is blue with white, or blue with blue and white. So these 4 become very important, and the last one that you people need to remember before the exam is carbon dioxide. Gray in color, and the number is 16 or 26. That depends on the percentage of oxygen. So how are these numbers given? 1, 2, 3, 4, 5, 6 and 7. So what they did was they gave each gas one number. So 1 and 5 was given to air, 2 and 5 was given to oxygen, 3 and 5 was given to nitrous, the single number 7 was given to Entonox. So as you can see, that is what makes the difference over here. So you will see this 3 and 5 is the same number as 1, 2, 3, 4, 5, 6 and 7. So 3 and 5 is what you see over here. 2 and 5, this is what is oxygen which you see over here. Brown helium, ठीक है, brown is helium, but they don't ask you so much in the exam, hence I didn't go into the details. ठीक है, but अगर एक extra information में क्या जाता है? Helium normally comes as heliox, which is brown with white. Number is 2, 4 and 4, 6. Okay, that is helium. ये कलर हो गया वेपोराइजर का कलर. Halothane, fiery red in color. Sevoflurane, the most common, I told you, my drug of choice, your drug of choice, doctor, my drug of choice, sevoflurane. So sevoflurane is yellow in color, light color, soothing color. Similarly, desflurane, blue in color, and you have isoflurane, which is purple in color. Now you find this question was asked last year in FMGE. This is identify the image. You find the desflurane vaporizer is different from all other vaporizers. Can you see this? In structure wise, this looks same. Structure means like this. Structure wise, this looks same. Structure wise, this looks same. This is big. This is different, right? The way of injecting it inside is different. So this vaporizer is different because desflurane boils at 23 degree or room temperature. Hence, it needs a special vaporizer, right? And this special vaporizer is what is electrically heated. It has the electrical supply, which is called as Tech 6. They won't ask you Tech 6, I'm just writing it down, but it's a special vaporizer. So remember, the one that needs a special vaporizer is desflurane. Okay, desflurane needs a special vaporizer, which is electrically heated. The last colors that you people need to remember is regarding the pipeline. The way we had the pin index safety system. So this pin index safety system prevents the wrong attachment of cylinder. This is called as the pin index safety system. It prevents the wrong attachment of cylinder. Similarly, to prevent the wrong attachment of pipelines, you have diametric index safety system, right? So this is what is called as diametric index safety system. So if this is nitrous, you can't put it where oxygen is. If this is oxygen, you can't put it where nitrous is. It's based on the diameter. Hence it is called diametric index safety system, right? Here again colors are coded. So this is what is called diametric index safety system. This white in color is oxygen. Blue is nitrous oxide. This black which you see is air. And all of you worked in wards, you know na, yellow color is for suctioning. So this is the suction which you get, or the vacuum which is there, right? Which is yellow in color. So this is about the pipelines. Okay. Dr. Pratyusha says desflurane and diametric index safety system. Correct. Absolutely correct. So we are done with the colors also, right? This was an important point. So image based में अपना ये भी खत्म हो गया. Correct. Let's go back to what we were discussing. Where were we? So we'll discuss intubation. Now laryngoscopes. Identify. Okay. Let's identify A, then identify B, and then identify C. Yes, anyone? 𝐒𝐿 curved, says Dr. Legendary Ritwik. Nice. और लोग बाकी B. अच्छा ठीक है. Macintosh, everyone said correctly. हाँ. So A is Macintosh, absolutely correct. Macintosh. This is used for adults and it is the curved blade. Very nice. B, what is this? Miller straight blade for children. Very nice. Correct. Miller is a short name and short means pediatric patients, right? So this is a straight blade used for pediatric patients. What is C then? What is C? Yes? C क्या है? मेरा मन तो कर रहा है कुछ बोलने का और मैं बोल नहीं रहा हूँ. I'm on YouTube. Had I been sitting in the class ना मैं कुछ बोल रहा था अभी. As soon as I said C, lot of things come into the mind. C. I'm talking of people from north. Maharashtra, Gujarat, north, everyone knows. Yes, C. What is C? जिसको समझ में आना तो समझ में आ गया. ठीक है. अच्छा नाम तो बताओ जो क्वेश्चन पूछ रहा हूँ. करेक्ट. असिस्ट difficult intubation में है शायद. Doctor, your drug of choice is saying that. So this is what is called as a McCoy laryngoscope, right? If you can see, there is a hinge joint here and there is a lever at the back. When you press the lever, the hinge joint gets pressed, right? And therefore this is what is used in a difficult intubation in anesthesia, right? So this has got a hinge joint and a lever. So why is now coming to pediatric and adult, why do you think in a pediatric patient you want to use a straight blade, in adult you want to use a curved blade? There must be some reason, right? So what's the reason behind it? Dr. Stay Happy says बोलिए sir. सिर्फ चार्जर USB-C नहीं होता. C is not only, not everything is USB-C. I'm not going to say it on the online यार. फंस जाएंगे हम लोग. Doesn't make sense. When we कहीं बैठे होते तो बात करते हैं C के बारे में. ठीक है, we can have a whole discussion on C. Lot of C. Forget it. Let's come back to studies. Okay. ये आ गया अपना blade. Can you see this? When you speak of a pediatric patient, when you're speaking of the airway, the pediatric airway is basically cone shaped. All of you would be knowing that. And the narrowest part of the pediatric airway is subglottic. MCQ question. If you see an adult, this is how the glottis is, right? It's a cylinder shaped. So the narrowest part is the glottis itself. Now, that is one difference. The second thing is when you speak of epiglottis, right? So epiglottis of a pediatric patient is long, floppy and hanging, right? In an adult patient, okay, let me put it the other way around from here. Right? It's so long, floppy and hanging this way, right above the vocal cord over the glottis of the patient. पीडियाट्रिक्स में एयरवे, हाँ करेक्ट, कोन शेप होता है, करेक्ट करेक्ट डॉक्टर एस यादव. एडल्ट में क्या होता है, ये नॉर्मली थोड़ा सा अवे होता है, it is slightly away. You know the epiglottis is like this in an adult. So what happens is if you put the laryngoscope over here, you are going to exclude the epiglottis in an adult patient. I am excluding the epiglottis. Can you see this? In an adult, that's why I use a curved blade. I am excluding the epiglottis. But if you talk of a pediatric patient, do you realize because it is long and floppy and falling over the glottic area, I am trying to include it during the laryngoscopy inside the laryngoscope. Difference. In a curved blade, the epiglottis is excluded. In a straight blade, the epiglottis is included. That is the difference because of the airway of the adult and the pediatric patients. And this is why you prefer to use a straight blade in a pediatric patient and we prefer to use a curved blade in an adult. And the reason is because of this epiglottis, right? It's because of the epiglottis. Omega shape, long, floppy epiglottis in children. Correct, Dr. Pratyusha, absolutely correct. Okay? Absolutely correct. Okay, so that is the reason behind it. So this is about the laryngoscope. So we've identified them, all the three. And what is 𝐒𝐿 used for then? Guys, what 𝐒𝐿 does is in case of a difficult intubation of an adult, it tries to lift up the epiglottis. Okay, that's the difference. It tries to lift up the epiglottis. So that is what the 𝐒𝐿 does. Next, what is this position called? Laryngoscopic position. Position for laryngoscopy. Yes, पोजीशन फॉर लैरिंगोस्कोपी क्या बोलते हैं इसको. और अगर कोई बोला रोज पोजीशन तो देखना, रोज इज रॉन्ग, इट इज नॉट कॉल्ड रोज पोजीशन. करेक्ट, correct, absolutely correct. This is what is called as the sniffing position. You can also call it as the 𝐒𝐿 position. Some people like to call it the barking position. अरे कुत्ता भौंकता भी तो ऐसे ही है. Sniffing, barking, all are the same. ठीक है, so sniffing position, it is also called as the 𝐒𝐿 position and it's also mentioned as barking position, right? What is happening is basically you are causing a head extension at the atlanto-occipital joint and there's a neck flexion at the lower cervical spine. This is again exam question, huh? Head extension, correct, flexion of cervical spine and extension of atlanto-occipital joint. Dr. Pratyusha says correct. ठीक है, so head extension at the atlanto-occipital joint, neck flexion at the cervical spine. What happens is, how do you make the position? You always keep 8 to 10 centimeter pillow under the occiput, right? And by doing this position, what is happening with head extension and with neck flexion, the three axes come in one line. So head extension at atlanto-occipital joint, neck flexion at the lower cervical spine, you get the oral axis, the laryngeal axis and the pharyngeal axis all coming in one line. And once they come in one line, it eases the laryngoscopic view. And that is why you make this sniffing position or 𝐒𝐿 position. And if it becomes difficult, if you cannot see it, you know, you do those maneuvers, optimal external laryngeal manipulation or the burp maneuver. I mean, it sounds so difficult, but basically you must have seen pediatric patients or even adults. We try to hold the larynx of the patient and try to move it left or right. That is what is called laryngeal manipulation, OELM, optimal external laryngeal manipulation and backward, upward, rightward pressure. Okay, so this is about laryngoscopy position and what happens in the position and the questions which are asked over from here. Next, endotracheal tube. Now, endotracheal tube we can talk about for hours and hours, but let's discuss what is the important point from the exam point of view regarding the endotracheal tube. The first point is over here that this is called as the connector or the machine end. ये पीछे का part है, which goes onto the ambu bag or the anesthesia machine. This is called as the bevel. Bevel is what is the patient end, which goes inside the patient's trachea, right? Now there is some point over here. Anyone? What is this called? This point? Okay, what is that point called? Can you see it? यहाँ पे भी दिख रहा है. If you will see, यहाँ पे भी you will see something like this. ये. What is this called? Correct, Murphy's eye. Very nice. Very nice. This is called as Murphy's eye. And why is Murphy's eye given? Murphy's eye is an additional port for oxygenation. In case the bevel gets blocked, in case you have an additional port for giving oxygen to the patient, you know, at least the patient will not die. It's a safety mechanism, basically, safety mechanism, right? In case the bevel gets blocked by secretions or blood or, you know, whatever is there in the patient, trachea, in the trachea. So this is at least an additional port there from where oxygen can go to the patient, right? Beyond that, you get this cuff. This cuff is basically, again, exam question, high volume, low pressure cuff asked in the exam. High volume, low pressure means if this is the trachea and this is the endotracheal tube, this cuff is a high volume and low pressure, means the volume is high. If you will see, this is the volume. It's a high volume. But what happens to the pressure? The pressure gets distributed on the tracheal wall. You will see the tracheal wall, the pressure has got distributed. Compared to another endotracheal tube, which might be low volume but high pressure. Okay, so this tube which you will see is low volume and high pressure. The volume is low, but can you see pressure is at one point. So this is what is called as low volume, high pressure cuff, but what we normally use is a high volume and low pressure cuff. Okay, so high volume, low pressure cuff, that is important. When you inflate the cuff, you inflate with 5 to 10 ml of air or saline. More important is the cuff pressure should be less than 25 to 30 centimeter of water. If it increases, you're going to cause pressure necrosis. If it is less, it can cause leakage and aspiration. Next point, what is this? What is this line called? ये क्या है? Dr. Pratusha has given correct answer. Huh? For confirmation of endotracheal tube correct position, capnography. For confirmation of, this is Dr. Pratusha's question. For confirmation of ET tube placement, capnography. हाँ, capnography and fiber optic, Dr. Pratusha. Capnography and fiber optic. I'll come to that also. I'll include that. Okay. Anyone first? What is this point here? ये black mark क्या है? This is what is called as the vocal cord guide or a vocal cord marker. ठीक है? So vocal cord marker is supposed to lie at the vocal cord, right? This is a vocal cord marker, correct? So this is your high volume, low pressure cuff. Okay, this is the bevel, this is the black line. Okay, vocal cord marker, right? It's supposed to lie at the vocal cord. It tells you the adequate depth of insertion, hence that black line is there. Remember, that's not the radio opaque line. The radio opaque line is this blue line which you see. This is what is called as the radio opaque line that is seen on the X-ray. This line here that you see, this is called radio opaque line. So the vocal cord guide is supposed to lie at the vocal cords. Then next written is ID. This is the internal diameter. Remember, internal diameter is the size of the endotracheal tube. Also, another point, the resistance of endotracheal tube depends on the internal diameter. This was a FMGE question, twice or thrice they have asked in the last 3 years. Resistance of endotracheal tube, it depends, inversely proportional. It is inversely proportional to the internal diameter. Okay, so that is about the internal diameter. These are centimeter markings from the tip. In a male patient, you keep 21 to 23 at the teeth. In a female patient, we keep 19 to 21 at the teeth, right? So these are those centimeter markings, right? This is the pilot balloon and the inflation line. They will not ask you, but this is from where the air goes inside. You put the air from here and this goes here inside the cuff. Okay? Hopefully people have understood till here, right? So endotracheal tube also we have done. If there are any questions, ask me here. So I'll come to the confirmation. Acha, one more point. This was oral endotracheal tube, right? So when you're intubating someone, apart from oral endotracheal tube, you can also put a nasal endotracheal tube. A nasal endotracheal tube is inserted in case there is a oral surgery to be done, or if there is a oral mass, so you can't access the oral cavity, and if awake intubation is to be done, especially fiber optic, long-term intubation in ICU, a patient in the ICU, long-term ventilation. So these are the reasons why you will put a nasal endotracheal tube, right? So oral mass, oral surgery, decrease mouth opening, This is the reason where you will put a nasal tube. Contraindication to nasal tube is more important. Imagine you're trying to put a nasal tube and someone has a fracture base of skull. Your tube will go in the brain. So the most important is fracture base of skull. CSF rhinorrhea, that means the connection between the CSF and the nose. Again your tube will go into the brain. So that is CSF rhinorrhea. Right? Now someone has a nasal polyp, nasal adenoma, retropharyngeal abscess, nasopharyngeal abscess, or retropharyngeal abscess. So any nasal pathology, any nasopharyngeal pathology, any retropharyngeal pathology, don't put a endotracheal tube through the nose. Coagulopathy, bleeding in the nose will take place, right? The last thing is someone has having fracture face. This is fractured, this is fractured, this is fractured, this is fractured. How will you put a nasal tube? So fracture of the face or a facial fracture, you can't put a nasal tube. And the same thing, in a fracture face, you also can't put a face mask or you can't use BiPAP, CPAP. Remember this question has been asked, huh? Someone is having a fracture face, you cannot use BiPAP or CPAP because CPAP is supposed to be put on the face itself. So that again brings a contraindication to BiPAP and CPAP. Okay? Yes or no everyone? Okay? So fracture face is one of the contraindications. Acha, if they discuss kare to let's write down other contraindications for that. If I'm discussing BiPAP, CPAP. So remember BiPAP and CPAP, if the patient is unconscious, it is a contraindication. If the patient is highly sedated or not breathing, because the patient has to be spontaneously breathing, this is contraindication. Also, if someone is having fracture face or someone who cannot tolerate the mask, okay, so here BiPAP and CPAP are contraindicated because there are masks going on the face. So unconscious patient, highly sedated patient, not breathing and fracture face are contraindications to use of BiPAP and CPAP. Okay, ये भी हो गया. Confirmation. Dr. Pratyusha was asking me that question. So the best in fracture face is tracheostomy. Oh, good question. Let me discuss that also. यार मेरा extra page नहीं आ रहा है. एक second. I wanted to use. If you guys give me 1 second, let me save it and I want to open it 1 second. एक second. Somehow that's not working here. I want to take a new page, I'm not able to take that. Anyways, let me start from here. Stay happy says sir guitar. देखो गिटार तो इधर ही रखा हुआ है यार, तो पढ़ाई करना है कि गिटार बजाना है? गिटार तो लेके घूमते हैं. चलो गिटार बाद में कर लेंगे. Okay, we were discussing an important question here. गिटार साइड में रहता है. Which song? First you think that. We were discussing regarding the tracheostomy or a patient who's got a fracture face. So remember, that would all depend on the type of injury which is there or whether it is elective or emergency. So let us make a situation like this. If the patient is having fractured cervical spine or if the patient is having a maxillofacial injury, I want to use a separate page. Where do I go? Okay, let me put it here. So imagine if a patient is having a cervical spine injury, maxillofacial injury, मतलब face का injury हो गया, face का fracture है. In case of an emergency, irrespective of the type of injury, you are supposed to put a oral endotracheal intubation if the patient is dying. If it's an emergency airway management where the patient is dying, you will not wait for tracheostomy or a nasal intubation. If a patient is dying, it's an emergency airway that you need to do, just intubate the patient orally, save the life. Now, if it is an elective airway management, okay, it's not emergency, elective airway management. If it is an elective airway management, यहाँ पे the things will become different because now the patient is normal, patient is breathing. So if it is a cervical spine injury, you are not supposed to move the neck. So tracheostomy is out, oral is out. You can try a blind nasal intubation. Okay, blind nasal intubation. And if the patient is having maxillofacial injury, face, in that case you will not do anything on the face. Here you will do tracheostomy. Is it clear, everyone? Thumbs up, everyone. That was a good question from your drug of choice doctor. Your drug of choice. Yes, let me know. Or if you have a problem over here, this is an important question. Dr. Pratusha says blind nasal. Yes, blind nasal. Right? This was a good question. Huh? It is asked in the exam. हर दूसरे तीसरे साल ये क्वेश्चन पूछते हैं. Good you asked me. Okay, so let's go to the next one. Hopefully तुम्हारा रिवीजन हो रहा है ना, रिवीजन ही पॉइंट था ना अपना. ये करके उसके बाद लेट्स डू द LMA and after that what we will do is we will see the spinal. उसके बाद then we'll be done. I'll take about half an hour more. I'll take about half an hour more. So I was discussing, एक और क्वेश्चन था, किसका था? Confirmation of tube placement. Okay, Dr. Pratusha has a question that was confirmation of tube placement. So Dr. Pratusha, how do you confirm that the tube is placed correctly? Right? So there are two things onto it. First is the confirmation of depth of insertion. Right? Let me discuss that. How do you know that you have placed correctly? You know, endobronchial नहीं है, एक side नहीं गया, दूसरी side नहीं गया. The first thing is that you will find the vocal cord guide or the vocal cord marker at the vocal cords. Second, you will find that centimeter mark at the teeth. Right? Third thing is that radio opaque line which you have seen. Correct? And the cuff, this lies 2 to 2.5 centimeter below the vocal cord and 5 centimeter above the carina. These are four things which tell you the adequate depth of insertion. Okay, so these are the four things which tell you the depth of insertion of the endotracheal tube, that you have placed correctly. Right? Second point is, how do you confirm the correct position? So for that, guys, remember, though we auscultate, the best method to confirm is always capnography. Capnography, right? To confirm, because when you're doing capnography, carbon dioxide is going to come from the trachea. It's not going to come from the esophagus. So therefore, if capnography graph is coming, it means carbon dioxide is coming out for sure. If you have put the tube inside the esophagus, there is no carbon dioxide coming and you start getting a flat line on the capnography. Hence capnography is the best. But people say now, because we have fiber optic also, so what happens in fiber optic is this is a direct visualization, means through a fiber optic I can see directly the vocal cords and I can see that my endotracheal tube is passing through the vocal cords. Okay, so therefore this fiber optic also is an important confirmatory thing because it gives you a direct visualization. Direct visualization. Okay, so capnography and fiber optic are most important. Apart from that, of course, we all do auscultation. Remember, stomach absent and equal at the lung bases and the lung apex. So that is why it's called 5-point auscultation. First point is absent at the stomach and equal at the two lung bases and the two lung apex. Hence it is called a 5-point auscultation. Right? Dr. Pratusha, both the doubts clear then? Apart from that, there are various indirect signs. You know, this is made of plastic, so you can see a moisture over here, which is called as the mist or fogging. You can see the chest going up, which is called as the chest rise. Right? Apart from that, if your tube has gone inside the stomach and you give IPPV, it's going to inflate the stomach. If you have worked as intern in a hospital, you must have seen some senior must have intubated wrong. You know, they are also learning, nothing wrong. They must have intubated in the esophagus, and when you give IPPV from here, you get a noise, good, right? And the stomach gets distended. So if your tube is inside the trachea, then there is no gastric distension and there is no gurgling. So these are all indirect signs. Apart from that, you have the radiological methods that you can diagnose. I mean, you can see that from the X-ray, or also you can see it from the ultrasound. Clear? So these are the ways to confirm the endotracheal tube. Then, full stomach patient. Full stomach patient, you do something different, which is called as the cricoid pressure. What are full stomach patients? These are called as the risk of aspiration. Remember, in risk of aspiration patients, you cannot do a bag mask ventilation. Someone who's having risk of aspiration, if I do the bag mask ventilation, some oxygen is going to go in the trachea, but a lot of oxygen is also going to go inside the esophagus. And the one that goes inside the esophagus, remember I told you God, it's going to cause distension. And remember, this patient is full stomach. So if this oxygen goes inside the stomach, it causes further distension. You're going to cause a regurgitation and aspiration of the gastric contents. Therefore, in a full stomach patient, this bag mask ventilation is contraindicated. Last 2 years, continuous question has been asked. Okay. Okay. So bag mask ventilation. Dr. S. Yadav says, thank you, Dr. S. Yadav. Made my day. Yaar. He said best teacher for anesthesia. Good. Thank you. Loved it. But that's why we teach here. Okay, to hear something like that. More than that, if you people have understood, it makes my work get done. Okay, that's the reason. If you people have understood something out of it and it helps you in your exam, that is our take home, right? Thank you so much, Dr. S. Yadav. All right. Hopefully, people understand also. Now, so do you have understood the reason now why we are not going to do a bag mask ventilation in a full stomach patient? Because it is going to cause regurgitation and it is going to lead to aspiration. So what are the conditions which are called as full stomach then? So remember, full stomach patients are basically all the conditions which are normally said as risk of aspiration. And risk of aspiration can be one, that the stomach is full. Second thing, pregnancy or ascites or tumor or obesity. Matlab, full stomach means not food in the stomach. Anything in the stomach is full stomach. Remember that. Anything in the stomach is full stomach. Pregnancy, obesity, ascites, tumor, all that would become full stomach. Apart from that, if you have reasons of delayed gastric emptying like gastroesophageal reflux disease, diabetes mellitus, when you've got autonomic neuropathy when it is set in, the later stages of diabetes. So GERD, diabetes mellitus, here also you get delayed gastric emptying. You get delayed gastric emptying if a patient is on opioids or if patient has had head injury. Right, so these are all causes of delayed gastric emptying. These are all called as risk of aspiration condition. Remember, opioid side effect is constipation. You people know that. Okay. Now, apart from that, surgical causes like intestinal obstruction or volvulus or even hiatus hernia. Congenital causes: congenital diaphragmatic hernia, tracheoesophageal fistula, pyloric stenosis, meconium aspiration syndrome. This congenital diaphragmatic hernia, this question was asked last 2 years. Okay? Mostly a patient has come with a scaphoid abdomen, and what is not supposed to be done? The point was bag mask ventilation was contraindicated. You can see your previous year's question. Okay? So this was the question asked. CDH, congenital diaphragmatic hernia, bag mask ventilation is contraindicated. Okay? So because it's a risk of aspiration. So now in those conditions, especially people who are full stomach, I will not be doing a bag mask ventilation. From anesthesia point of view, when these people come for surgery, I do something different which is called as a cricoid pressure. Okay, a lot of people nowadays in anesthesia say, right, that cricoid pressure is not to be given, but yes, exam mein poochte hain, so we are supposed to study still, right? So what you need to do is pre-oxygenate the patient, which means before starting, you give 100% oxygen for 3 to 5 minutes. After that, right, patient is breathing spontaneously. You're not giving IPPV. Remember, risk of aspiration means no IPPV initially, no bag mask ventilation, right? So pre-oxygenate the patient. After pre-oxygenation, then what you do is you start giving the cricoid pressure. Cricoid pressure is different and this is different. You have to realize what this is. ये जो दिख रहा है यहाँ पे नीचे, this is what is called as optimal external laryngeal manipulation. Remember, I told you right now, OELM. If you can't see correctly, if you go back, can you see this? I told you OELM, optimal external laryngeal manipulation. If you can't see it clearly, so this is what is called OELM. This is done by the same person who is intubating, and cricoid pressure is given by a different person. This is the difference, and this has been asked as an image-based diagram. मतलब not in the exam when we have set up the papers. Okay, अभी तक ये वाला question exam में नहीं आया है. So this is the different person giving a cricoid pressure. It's not the same person. The person doing laryngoscopy, he is giving a pressure that is optimal external laryngeal manipulation, but cricoid pressure is given by someone else who's not doing the laryngoscopy and intubation. So cricoid pressure is normally given 30 Newton. You're giving it at the cricoid. What does it do? This is called as 𝐒𝐿𝑖𝑘's maneuver. It is called as 𝐒𝐿𝑖𝑘's maneuver. By giving cricket pressure, what you're doing is you shut off the esophagus and you're preventing the aspiration. After that, you give the drug of choice. Induction drug is given. Along with that, you give the muscle relaxant, right? Both are given. No IPPVs to be given, and straight away intubate the patient. Laryngoscopy, intubate, inflate the cuff, confirm the position, and only then release the cricoid pressure. Okay? Correct. That is 6 maneuver. Clear? ये भी हो गया. Identify. So this is an endotracheal tube which already has a preformed curve. Right? So this is what is called as a ring Adair Elvin tube. RAE. Ring Adair Elvin. This is a preformed curve. This is used for oral and maxillofacial surgery. Right? So you will find if the curve faces the north, I mean if the connector faces the head of the patient, it is called north pole. If the connector faces the leg of the patient, it is called south pole. Right? So this is what is called as ring Adair Elvin tube, RAE tube, or a preformed tube. This is what is called as a flexometallic tube or armored tube. ठीक है, इसके अंदर एक स्पाइरल मेटल वायर होता है and this prevents kinking of the tube or bending of the tube. The tube does not bend. This is important in a prone position surgery. Imagine किसी का prone में surgery चल रहा है and the tube gets bent, patient is gone. So in a prone position surgery, spine surgery, neurosurgery and major plastic surgery is where we use this, which is called as the flexometallic or armored tube. Okay, correct. Dr. S. Yadav says correctly. Okay, head surgery. So prone, spine and neuro is where we use it. This is what is called as a double lumen tube. There are two lumens. Can you see this? This is called as a double lumen tube. It has got two cuff. Can you see this? Two lumens and two cuff. So this double lumen tube isolates the lung and it is used for one lung ventilation. This is used for thoracic and mediastinal surgery. Right, so these are the types of endotracheal tube. Now let's go to the next one. LMA. Remember, laryngeal mask airway is classified into two types. Okay, laryngeal mask airway. Of course, they are going to lie at the larynx. One which has one tube, other which have two tubes. If you can see, this one has one tube. These have got two tubes. This one also has two tubes. So the one which has one tube can be lot of them. Normally, what was the first one is called classic LMA, otherwise AMBU LMA, intubating LMA. So these are all one tube. The tube you get only three of them, right? So one what you get here is a airway tube, and the second one is a drain tube. Okay, airway tube and a drain tube. Airway tube का मतलब होता है यहाँ से ऑक्सीजन जाएगा पेशेंट के ट्रेकिया में, and from here you put a Ryle's tube that goes inside the stomach, which can do the suctioning from there. Similarly, if you will find this, oxygen goes from here inside the trachea, and a Ryle's tube from here goes inside the stomach. This is the two tubes, right? So here you are in two tubes, you are having three of them. One is called the Procele LMA. Hey, this was this year's question, huh? INICET question hai ye, Procele LMA. This was INICET question, huh? This year, May. Procele LMA. Then you get iGel and LMA Supreme. These are two tubes. Okay? So LMA Procele, this question was asked. Right? So when you see the laryngeal mask airway, right? So if you'll find laryngeal mask airway lies at the larynx, remember it's outside the glottis. If this is the vocal cord, it is outside the glottis, so it is supraglottic device outside the glottis. And you will find the tip of the LMA lies at the esophagus, right? So these are three important points. It lies at the larynx, it is supraglottic, and the tip lies at the esophagus, right? The tip lies at the esophagus, right? So now the point is, it is not preventing aspiration. In case you are giving oxygen from here, remember bag mask ventilation, some oxygen can go here and some can go here. So therefore the same thing can happen here also. So if I give IPPV from here in a classic LMA, single tube, if I'm going to give it from a single tube, right, classic LMA, I give oxygen, it can cause distension of the stomach also, which can cause aspiration. So some oxygen will go here and some will go here. This will cause aspiration also, regurgitation and aspiration. Hence they made a double tube. By making a double tube, what happened was they used this space to put a Ryle's tube that can go inside the stomach, and now you can do a suctioning from there. So the biggest advantage of using this two tube is that this drain tube can be inserted inside. From here you can insert a Ryle's tube or a nasogastric tube inside the stomach, and therefore this two tube can be used for IPPV also. Here IPPV is contraindicated. नहीं, of course intubating LMA की बात तो कर सकते हो, but ideally IPPV में नहीं use करते हैं. यहाँ पे this can be used for IPPV also. Clear everyone? So these are the LMA. When you use the LMA, remember guys, LMA needs no muscle relaxation. It needs no laryngoscopy. It is easy to insert. It's a very good alternative to intubation. The only difference is that in intubation, the endotracheal tube goes inside, it has a cuff, and therefore intubation, what does it do? It prevents aspiration. LMA does not prevent aspiration because the cuff is outside and not inside the trachea. Okay, so LMA does not prevent aspiration. Okay, you guys, any questions? कोई doubts? किसी को? कोई कहाँ गया? Yes guys, any questions, any doubts? Disadvantage of LMA, risk of aspiration is high, correct? Okay, so disadvantages of LMA. So disadvantages of LMA can be risk of aspiration, absolutely correct, says Dr. Pratyusha. Apart from that, you can also cause laryngospasm, right? This can get folded over here. So there are high chances of laryngospasm. There are high chances of gastric distension and vomiting. So these are the disadvantages. Also, you can't use in obese patients, very obese patients. So aspiration, laryngospasm, gastric distension and vomiting. These are the disadvantages. Clear, Dr. Pratyusha? Okay, next. ये तो हो गया अपना oropharyngeal airway. Everyone knows that Goodell's airway or mouthpiece. It prevents the backfall of tongue. ठीक है? This prevents the backfall of tongue. Right? This device basically is contraindicated in an awake patient because in an awake patient it can stimulate the gag reflex. So if you put in awake patient, it can stimulate the gag reflex. And this stimulation of the gag reflex can cause laryngospasm, can cause vomiting, and can cause aspiration. Therefore, contraindication is important. You will not use it in an awake patient. And therefore, in an awake patient, what you can use is nasopharyngeal airway. Right? So this is what is called as a nasopharyngeal airway or the NPA. Remember, it goes from the nose, huh? Remember all the contraindications of the nasal endotracheal tube? The same hold true here also. Fracture base of skull. Remember? CSF rhinorrhea, coagulopathy, nasal, nasopharyngeal, retropharyngeal. ये सब same, just like the nasal endotracheal tube. It's the same. So this also does the same thing. It prevents the backfall of tongue, but it is inserted from the nose. Right? Biggest advantage is I can use it in an awake patient because it bypasses the gag reflex. I can use it in awake patient, that's an advantage. It bypasses the gag reflex. Right? Dr. Pratyusha says oropharyngeal airway, Goodell's airway prevents the backfall. Correct. Absolutely correct. ठीक है, तो ये सब हो गया अपना. Bag mask ventilation. Side effect. Anyone? Of course, it can cause trauma here. It can cause trauma here. वो सब तो है. What is the biggest disadvantage of bag mask ventilation? Anyone? I'll give you one hint. Bag mask ventilation, if you will see, is providing you with an area that contains oxygen, and this is not taking part in gas exchange. Anyone? What does it mean? You are increasing an area that contains oxygen and does not take part in gas exchange. That's the hint. Anyone? What's the answer? Anyone? So let me tell you, this is increasing the dead space. This is increasing the dead space. Dead space gets reduced by intubation or a tracheostomy. Bag mask ventilation is increasing the dead space. Okay, chalo, ye bhi ho gaya. Next, so we have to discuss last that we were thinking is spinal, the layers and all. Okay, anything else that you people want, let me know. So this is your spinal, this is your epidural, and as I said, I'm going for more image based questions and previous year's topics which were there. Okay, so the difference is spinal needle is thin, it is given single shot. But if you look at the epidural needle, can you see there are 1 centimeter marking, and you are going to put a catheter from within. So Dr. Pratyusha ka answer abhi aaya, increasing the dead space, which is correct. Okay, so I'm discussing the spinal and epidural. So epidural is a catheter which is inserted inside. So okay, so that's the epidural that we are talking about. This is the epidural needle. If you will see, epidural needle is called a 2E needle. It has got 1 centimeter marking so that you come to know how far you are from the skin. It is normally thick so that you can pass a catheter from within. Also, if you will see the tip is curved, okay, so that you don't damage the structures beyond, right? So the tip is curved, which is called as the Huber tip, right? So this is the epidural needle. Remember, it has 1 centimeter markings. That's how you can identify in the exam. Correct, Dr. Pratyusha. It's a 2E needle. Okay? It is 2E needle. It is thick. You can pass a catheter from within, and this needle has got 1 centimeter markings. If you will look at the tip, can you see the tip is curved? This tip is curved. It's called the Huber tip. Let's see the next needle. This is what is called as a spinal needle, right? Two of them. There's also a spinal needle. But what's the difference between them? The first spinal needle that you see has got a tip which is bevel. It's got a bevel tip. This is called as a dura cutting needle. Dura cutting needle, because there is a bevel, it cuts the dura. If you will see, if it cuts the dura, what does it do? It leaves this much dural rent from where there is CSF loss that takes place. Okay, so this is the dura cutting needle. It cuts the dura. Examples are 𝐒𝐿𝐄𝐝 and Pitkin. 𝐒𝐿𝐄𝐝 and Pitkin needles. Okay, so dura cutting needles are 𝐒𝐿𝐄𝐝 and Pitkin. Alright. Then this needle that you see, it causes more damage to the dura and more incidence of PDPH, post-dural puncture headache. This was an important question, and I think this was asked even in this time FMGE. Okay, so this is the dura cutting. Dr. Aditya says dura cutting means. Okay. Wait, so before I go to dura cutting, let me discuss the layers then. Okay. I'm coming there. Wait. So when you are going to give a spinal, guys, what are the layers that get, punctured? This is a common question that they ask you. So the first layer that you're going to get from here is the skin, right? The second layer is the subcutaneous tissue. So this everyone knows that. The first layer is the skin, second is the subcutaneous tissue. The third layer is something covering up the spinous process, which is called as supraspinous ligament. Then you get a ligament which is in between the spinous process, which is called as interspinous ligament. So here you don't have to remember anything. These four are easy, right? So The first layer is the skin. Here is the skin, then is the subcutaneous tissue, then you get a layer covering up the spinous process. This is called as the supraspinous ligament. You get a layer in between the spinous process, which is the interspinous ligament. Now what is this layer then? After that there is one layer which you get. ये layer क्या हो गया? Anyone? What layer is this? After the interspinous ligament, what layer you are getting? This was the interspinous ligament. What layer is this? Anyone? So skin, subcute, supraspinous, interspinous, 4 layer हो गया. That's again a ligament which you see, which is seeing over here. This is again a ligament, okay? And this ligament is called as ligamentum flavum. This is important. This is called as ligamentum flavum. Okay? After the ligamentum flavum, then my point is, what is this layer? Once you have crossed ligamentum flavum, what layer is this? So as soon as you cross ligamentum flavum, guys, remember you have reached the epidural space. So till now you have not reached the spinal, you have already reached the epidural. After, and why is it called epidural? Epi means extradural, outside the dura. So epidural, just remember, means is extradural or outside the dura. Outside the dura, which means the next layer that you get over here, this is the dura. Along with the dura, ekdam close to that lies the arachnoid. Dura and arachnoid are almost stuck onto each other. Okay, and then you get this layer in between this point, and this is your subarachnoid space. So all this is what is called as the subarachnoid space. All this is your subarachnoid space, and subarachnoid space is what contains the CSF. If you will see, this is what is containing the CSF. This is where all the nerves are there. This is where is the spinal cord. So this is what is the spinal cord. Spinal cord starts from medulla oblongata and it goes up to L1, L2 in adult and L3 in a child. ठीक है, L3 तक जाता है, and because it is going up to L1, L2 in adult, so imagine you have to give spinal anesthesia, and I give at L1 level, I am going to puncture the spinal cord. I can transact it. So therefore spinal anesthesia is always given below L1, L2, so that you don't damage the spinal cord of the patient, right? That is the reason why you always give commonly at the L3 and L4 interspace. If this was L3, this is L4, I am going to give, this is the most common site, L3, L4. You can also use L4, L5, but the most common is L3, L4 for giving spinal anesthesia. So remember, the subarachnoid space is what contains the CSF, and this is where you give the spinal anesthesia. Okay, this is where you give the spinal. So spinal is more inside, and you are going to puncture the dura, right? Epidural was outside. So when you give an epidural, remember in epidural space, this was the dura, here is the arachnoid. So in epidural, the needle is thick, the needle is curved, and I will pass a catheter inside. So if I pass a catheter, but I have not punctured the dura, remember dura is a meninges, dura and arachnoid are meninges. But when I am giving spinal anesthesia, guys, I am going to puncture the dura. So if I puncture the dura, होगा क्या? Dura में एक hole रह जाएगा. And this is a meninges. Meninges कहाँ है? Meninges is going here, brain. So if you are making a hole in the dura, right? So if you are making a hole in the dura, from the dura CSF starts to leak, and because of that there is causing a stretch of the meninges, and the stretch of the meninges is what is causing the post-dural puncture headache. The reason is CSF leak. Okay, and that is why you are trying to use the needle. So if you use a needle which has got a beveled tip, so what this bevel does is, if this was the dura, so if this needle is there, it has got a bevel tip, it is going to puncture like this. So once the CSF is getting out, once you're given the spinal, imagine how much CSF leak this is going to take place more. So more incidence of PDPH. On the other hand, this needle which you see is called as dura splitting needle. It splits the dura. Dura splitting needle. It can also be called as dura separating needle, right? And the examples are Whittaker, right, and Sprott. These are the names. This is also called as a pencil tip needle. Pencil tip needle. Pencil tip means, can you see the tip is like a pencil? So what happens is, now this is the dura, you got a pencil tip needle like this. And this is dura separating. So what it will do is, it's not going to puncture the dura. It's just going to make a small rent over there. So therefore the CSF leak is less. And there is less chances of PDPH. Clear everyone? Here you get more PDPH, that was the bevel, right? That is the meaning of bevel and dura cutting needle. And here you get less CSF leak, less PDPH, and this is the dura splitting or the pencil tip needle. Okay, so this was the doubt for Dr. Dr. Aditya. Dr. Aditya, okay? Any other questions, guys? So we are done with this part also. The important thing that I wanted to discuss was the layers, the needles, all right? The names of the needles. And when you get PDPH, guys, when you're getting PDPH, the CSF leak, it causes post-dual puncture headache. What is the treatment for that? The treatment will be, first, try to give IV fluids or maintain hydration to the patient, because that is what is going to produce the CSF. The stretch of the meninges will be prevented. You can use analgesics, caffeine. Remember, stool softeners are used. Right? You can use drugs like gabapentin, sumatriptan, all those drugs can be used. Right? Steroids can be used. Gabapentin, right? Sumatriptan. But the most important thing, the most definite treatment, these are all treatments which are there, but the most definite treatment is what is called as a epidural blood patch. Dr. Pratyusha says the answer. Chalo, theek hai. Any koi doubt to nahi yahan pe, guys? So we have finished off that PDPH also. So last, what I will do is, I'll just discuss 2-3 monitors that you people need to know. Okay? The images which are important for the monitors. So I'll take about 5-10 minutes more and we'll be done. Any doubts till now, guys? Yes? Anyone? So we'll just finish off the last part. About 10 minutes we'll finish off the 2-3 monitors which are there that you people need to know. Important ones. Right? कोई doubt तो नहीं किसी को? You people have stuck on for so long. सब लोग बैठ के सुन रहे हो. Good. Thank you. Okay, let me go forward then. This is what is called as the bispectral index. This is depth of anesthesia monitoring. Depth of anesthesia monitoring. Right? This is called as a bispectral index. You are monitoring how deep is the patient under anesthesia. How do you monitor that? By EEG, electroencephalogram. So what you have done is you have attached electrodes of EEG on the forehead. Based on that, you are going to get a value between 100 to 0. 100 means the patient is awake. 0 means flat line EEG or coma, sort of coma. 40 to 60 is the adequate level for general anesthesia. 60 to 80 is set for sedation. So therefore, when you are giving, thank you Dr. Pratyusha for your answer. Okay. When you're giving general anesthesia, the level should stay between 40 to 60. When you're doing sedation, it is between 60 to 80. Okay. So GA, what it happens is that, imagine if this patient was under GA and you get a value 91. It means patient is intubated, surgery is going on, and value 91 means the patient is awake. So you increase the dose of anesthesia, right? So therefore, if the patient is awake, surgery is going on, you get 91, this patient will remember everything. That is called awareness under anesthesia. So therefore, what you do is you increase the anesthesia. Therefore, you try to get this level to around 40 to 60. Here, the EEG will detect that now the activity is down and the patient is sleeping and not awake, right? Now imagine under GA, patient is intubated, surgery is going on and the value is 20. Imagine now the patient is going towards coma. So you need to stop your anesthesia. So what happens is this helps you, bispectral index or depth of anesthesia helps you to maintain the optimal depth of anesthesia. It helps you to maintain the optimal depth, means during the surgery how deep should be the patient, neither too much nor too less. So overdose and underdose of the drug are both prevented and the patient is comfortable during the surgery. Okay, so this is what is called as depth of anesthesia monitor. This is bispectral index. It is based on EEG. There's another one called entropy. Entropy is EEG plus EMG. Okay, which is a better monitor than bispectral index because it combines two things, EEG and EMG. EMG means electromyogram. So you're coming to know regarding the muscles also. EEG just told you about the brain, but entropy is going to tell you both the things. Otherwise, routinely for muscles, what we use is neuromuscular monitor. This image was asked in the exam. This tells you about the muscle paralysis. So this what you see is called as a neuromuscular monitor. Neuromuscular monitor is something that monitors the muscle paralysis of the patient, whether the muscles are paralyzed or not. Okay, because the surgery, the periphery you get, when someone is lying down on the OT table, you get the periphery free. So that's why we use the ulnar nerve most commonly. So the most common used site is the ulnar nerve, right? And corresponding, so this is the ulnar nerve which is used, and corresponding to that the muscle is going to be the adductor pollicis muscle. This is the most common, but some people say the best, some books have mentioned the better would be to use a facial nerve. Even that can be used, a facial nerve and the orbicularis oculi muscle. Now imagine hand surgery is going on and you still want to monitor the paralysis, so you can use the facial nerve also, right? And if hand and face both is going on, then you can use the posterior tibial nerve, but let's not go into so much details. Okay, so therefore neuromuscular monitor means one nerve and the corresponding muscle is to be monitored, right? It tells you whether the muscle paralysis is there or not there. So this is your neuromuscular monitor. What happens is, here normally the most common used mode is called as the train of 4 mode. Train of 4. Train of 4 means I'm going to give 4 stimulus over here and I'm trying to see 4 responses over here. So therefore, if there is no paralysis, you are going to get the same response. What I'm going to do is, each stimulus is of 2 Hertz. It is given in a span of 2 seconds. Means every stimulus is at 0.5 seconds. So 2 seconds में 4 stimulus, 1, 2, 3 and 4. If there is no paralysis, you get all the movement which is normal, right? And if complete paralysis, make no movement. Otherwise, if you use a non-depolarizing muscle laxant, right? In this case, if there is a paralysis that you see, right? It's over after some time. In this case, you will get to see in a partial one, what you get to see is fade. Fade. Succinylcholine, it's going to show you less amplitude but same height. So this is fade, right? Which is seen is a hallmark of non-depolarizing. But what happens is, succinylcholine has 2 types of block. One is phase 1, other is phase 2. So when succinylcholine is phase 1 block, you get to see decreased amplitude, same height. But if you get succinylcholine phase 2 block, it means it is going to show fade, because succinylcholine in phase 2 resembles the non-depolarizing block. Okay, so that is the point, that this helps you to differentiate between the types of block also. You come to know 2 things, whether the muscles are paralyzed or not paralyzed. Second thing, it helps you to differentiate between the types of block. Non-depolarizing from succinylcholine phase 1 and succinylcholine phase 1 from succinylcholine phase 2. This is your neuromuscular monitor. Thumbs up everyone, is that okay? So this is your neuromuscular monitor. Okay, last, which is very important, which I feel, second last one, this is pulse oximeter. Pulse oximeter is based on the Beer-Lambert's law. It is based on the blood supply which is going to the periphery and the light passes through it. Okay, so what happens is, there is oxygenated hemoglobin and deoxygenated hemoglobin. Light passes through both of them. It calculates some calculation based on the photodetector, and based on that, the difference which is seen, you get to know the SpO2 of the patient. SpO2 should normally be more than 95%, right? Apart from that, you also come to know about the peripheral perfusion of the patient. Means this blood supply that is happening to the periphery, you come to know about that. right? So peripheral perfusion is what you come to know. Based on that, you come to know the heart rate or the pulse rate of the patient. You can also know the arrhythmias, and if the patient is in arrest, it will not pick up, right? When do you get a wrong reading? You get a wrong reading if the hemoglobin is damaged, dysfunctional. For example, if it is a methemoglobinemia or carboxyhemoglobin, not in jaundice. In jaundice, the hemoglobin is not damaged, it's broken down. Okay, so normally in jaundice, ideally it does not show a wrong reading unless there is too much of yellowish discoloration. Because of the color, it might interfere with the light. But otherwise, jaundice per se does not give a wrong reading in pulse oximeter. Remember that. Okay, so that's the point. Okay, so methemoglobinemia, you can get a wrong reading. Carboxyhemoglobin, you get a wrong reading. If the perfusion is decreased, for example, if patient is in hypotension, hypovolemia, or in shock, you get a wrong reading. Similarly, someone is in hypothermia, right? Hypothermia, and you get, apart from hypothermia, if there is vasoconstriction due to any reason, there is shivering due to any reason, you get a wrong reading. Apart from that, mechanical interference, nail polish. Okay, nail polish हो गया. Then there are dyes, varnish. Okay, then there's lot of ambient light in the room. And last is, even books have mentioned dark skin also. पर मेरे skin पे ठीक आता है. I have checked mine also, it works. Books have mentioned ambient light, dark skin. Ambient light means lot of light in the room. So books have mentioned that also. Books have mentioned dark skin also, right? But these 2 points are normally not valid. In fact, nail polish भी pick up कर लेता है कभी कभी. I think nail polish also is okay, unless and until nowadays people have something which, you know, they stick on the nails. You know, nowadays girls have different types of nail polish. It gets stuck onto the nails. I'm not saying anything, but you can't come to a surgery with that kind of nail polish, na? In our hospitals, we get such patients. You know, you put on the fingers and they stuck onto the nails. Then you take the toes, it is stuck onto the toes. Then you think, okay, I'll take the ear lobule, then they have 10 earrings. Then you think of the nose and they have a nose ring hanging there. What to do here? You get all these situations. Okay, so that's the pulse oximeter. Hopefully you understood this one. Last one, capnography. Capnography is an important monitor. Capnography, guys, is a graph of carbon dioxide which is exhaled, which comes out. This point which you see, point D, this is called as EtCO2, end-tidal carbon dioxide, and this is the maximum alveolar carbon dioxide detected. So you have a monitor that you keep in front of the patient's mouth, and whenever carbon dioxide comes out, it gets detected. So let's go to the intubation part, where we were discussing intubation. Okay, where is intubation? Here. So let's take this patient. So whenever carbon dioxide from here comes out, there's a monitor that you keep over here. That monitor detects the CO2. Okay, whenever oxygen goes inside, then there is no CO2. So whenever the carbon dioxide comes out, you get a graph which goes up, right? Whenever there is oxygen going in, the graph goes down. Hence you get a graph like this. So whenever the graph is going up, it means carbon dioxide is coming out. Graph going down means inspiration is taking place. So that is the meaning of capnography graph. Okay, so correct, so that is EtCO2 here. ये तो we have discussed here. Where was I? Yeah, this is where we were. So maximum alveolar CO2. Okay, so capnography is basically telling you about the carbon dioxide of the patient, and this point D which I told you, this is end-tidal carbon dioxide or the maximum alveolar CO2. So capnography can also be called as EtCO2 or end-tidal carbon dioxide. So EtCO2 is the value. Normal value is 30 to 35. Okay, capnography. So capnography can be mainstream or side stream. And capnography graph, when you speak, so a normal graph like this means expiration, inspiration, expiration. Expiration means going up, inspiration going down. This means IPPV is going on. It means proper ventilation is going on. It means proper intubation has taken place. Proper intubation. But if you get a graph like this, this means your tube mostly is gone in the esophagus. Esophageal intubation, because it means there is no carbon dioxide detected, right? This can also be seen not like this, but something going down, a very low value like this. This can be seen in embolism, low carbon dioxide. Remember, embolism question has been asked as a clinical question. A decrease in SpO2 and a decrease in EtCO2. This was a clinical question asked. A patient is undergoing laparoscopy, under laparoscopic surgery, suddenly there is a fall in saturation, there is fall in EtCO2, peak pressures are normal. This question I think was asked last year, clinical question, 4-5 lines. The point is, if there's a decrease in SpO2, decrease in EtCO2 and the peak pressure remains normal, it means normally it is going to be an embolism, especially in a laparoscopic surgery where the chances of embolism are very high. Okay, so if it is going down, it can be embolism. It can be low cardiac output states, for example cardiac arrest. So all this would also be esophageal intubation, disconnection from the circuit, accidental extubation, all this can take place. If it is going very high, high means more carbon dioxide production, so this can be seen in laparoscopy. So that's the point. In laparoscopy, I would normally see EtCO2 going up, but if it goes down in laparoscopy, it means that there may be embolism. So laparoscopy ho gaya, high output states means high metabolic state means fever, sepsis, thyrotoxicosis. Okay, use of soda bicarb, this is very good. And if it increases and does not touch the baseline, means rebreathing own carbon dioxide. Step ladder pattern, it means rebreathing own carbon dioxide. Right? Then you get a graph which all of you already know, where it comes रुक रुक के आता है, ठीक है? This is called shark fin appearance, and all of you know this is obstruction. Okay? So you get a normal graph, you got a graph which is going down, a graph that goes up, rebreathing own carbon dioxide. Apart from that, you need to know another graph which is, let me take it here. Okay, apart from that, you need to know another graph which is like this. IPPV is going on and suddenly someone has tried to breathe. So this means return of spontaneous ventilation, means a patient is trying to breathe. Which brings me to one more point. In a normal patient, normally you get IPPV like this. But if you put this EtCO2 monitor in a patient who's breathing spontaneously, you get a graph like this. This is seen in IPPV and this is seen in spontaneously breathing patient. So if someone is getting IPPV and he tries to breathe spontaneously, you get a graph like this. You get a graph like this. Okay, so this is what is called as curare notch. And this means that patient is out of muscle relaxant effect. It means that return of spontaneous breathing. Okay, and then there is this graph which tells you something under inspiration. This was all about expiration till now. This is something about inspiration. This is called cardiac oscillations seen in people with thin chest wall. Cardiac oscillations seen in patients with thin chest wall. Last. What is this? This was INI-CT question. Wait, let me draw it properly. M-shaped pattern. Anyone? This was asked INI-CT. No, this is not curare notch. This is different. Curare notch is a very smooth slope, you know, it is going like this. This M-shaped pattern, okay, I have not given the option. Remember, this is what is called lung transplant. This was INI-CT question 2 years back. Lung transplant. First carbon dioxide from one lung and then from the other lung. Okay. So this finishes off whatever we had thought of, right? So thanks for joining with me and being together for 2 hours. I think all of you really gave answers and really like an interaction like this, you know. We had just like how we are sitting in a class. It was a lovely interaction with all of you. Any questions and doubts, please ask me. Any questions and doubts? So whatever I had thought of, we tried to finish off all the images, important points, right? That's why it's called das kadam, points, you know, which were needed. Any questions and doubts, guys? Otherwise, we have our one-shot revision also coming up on our app, huh? Like complete revision, 3-4 hours. We are going to come up with a one-shot revision, all of us. Okay. we're going to have that. This was a small session where I just try to, all of us are trying to cover up the image based questions and the previous year's topics as in a short span as possible, all of us over here. Thank you, Dr. S. Yadav. Anyone else? Any questions and doubts? Achha, if you want to get in any questions or doubts that you have for me, you can. This is my Telegram ID, Dr. Vinish, Vinish, Telegram, and my Insta ID is Dr.Vinish. So I'm trying to post up things on the Insta also, and that's my Telegram. Okay, so you guys can have that. Let me take the last slide, then I'll give it to you over there. Dr. Pratusha says all clear. Thank you, Dr. Pratusha. Okay. Okay, so let me just write it down. My Telegram ID, DRVINISH. Thankfully, Insta में भी अच्छा नाम मिल गया. I was thinking I'll not get it. So I just started with Insta. This is dr.vinish. Okay, so that is what it is. Yeah. Let's try to play a song. Let's see. I don't know whether it will be there through the YouTube में आएगा कि नहीं. But let me see if we can play something. हाँ डॉक्टर यस यादव, बेहोशी को डॉक्टर ही बना देता हूँ मैं. नेक्स्ट टाइम वही बनाऊंगा, एजुकेटेड ड्रग डीलर. ये कर लेता हूँ मैं. दैट इज व्हाट इज लेफ्ट नाउ. सही है. Thank you guys. Hopefully I was audible. I'm not sure if I was audible also, not with the guitar, but thank you everyone for joining me at this session. Okay, and any questions and doubts you can ask us. Thank you so much everyone. So I think, okay, so good night everyone, all the best, do well, you can get in touch with us and take care, all the best. अच्छा, डॉक्टर नवीन ने कुछ कमेंट किया. ग्रेट सर, थैंक यू डॉक्टर नवीन. होपफुली आई वाज ऑडिबल, आई एम नॉट वेरी श्योर आई वाज ऑडिबल और नॉट. अच्छा मुझे थैंक्स पहले से भी आ गया. थैंक यू यार. थैंक यू डॉक्टर प्रत्युषा. थैंक यू डॉक्टर एस यादव. Thank you Dr. Naveen Thakur. Thank you everyone for joining me at this session. Take care. All the best and do well. Okay. I'll sign off now.